As Suzanne was just saying, I've been working in the integrated COVID hub in the northeast since last September, the last 12 months. And if nothing else, it's kind of shown me how busy we all are. And I'm particularly grateful that you've taken a bit of time out this afternoon to reflect. And it's my intention the next hour or so to give you some time to reflect by following my brief of taking a kind of historical perspective of why we are where we are and what it is that we need to do next. And the story starts in Japan in many respects. And has anybody been to Kyoto in Japan apart from me? It's a beautiful city. This is a picture of the Kiyomizu temple, which is about the same age as Durham Cathedral. Although, as you can see, it's made of wood. And you can also see that it's sort of built on this trellis of tree trunks, which are held together just by the weight of the temple sitting on the top. Because it's an earthquake zone, the people who built it 1,000 years ago knew that they would have to flex every time the ground moved and so on. It's a wonderful temple, and it's one of about 100 temples in Kyoto, all of which are spectacular. And the reason we can look at a picture of it now is during the Second World War, the whole series of academics in America got together and lobbied the government to say, you can bomb anywhere you like in Japan, but don't bomb Kyoto because there's too many places like Kiyomizu that are too valuable. And as we know, quite a lot of, the Hiroshima and Nagasaki story is well known, but what's not so well known is nearly every other city in Japan was flattened by conventional bombing as well, leaving just Kyoto and places like Kiyomizu standing. So at the end of the Second World War, Japan was in a very, very parlous state. Most of their infrastructure had been destroyed by carpet bombing by the Americans. And their manufacturing industry, their service industries were equally damaged. And the story of how Toyota took what they'd been doing just before and during the war, they had been a textile company. But just before the war in the 1930s, they'd started to make cars. And then as Japan mobilized with its war with China and then the World War, Toyota became a big manufacturer, obviously, of vehicles for the war. Toyota took as their task the rebuilding of that kind of motor industry, the cars, the trucks, and so on that they started to make. And a man called Taiichi Ohno, who many of you will have heard of, is the sort of father of what became the Toyota production system. And it's the Toyota production system that sits alongside many of our kind of improvement techniques. And I often say it's the DNA of how we improve things. What is less well known to some people is that what Toyota did was very much use a man called Deming, Edward Deming, to advise them on how to get out of this parlous state where all their factories had been destroyed, their ability to build things had gone, their workforce had been severely affected by the war and so on. And Deming was an American academic who'd studied how it was that, again, productivity and manufacturing could be improved, and what it was that was wrong with the way we were led. What was wrong with management was one of Deming's big things, and I'll come back to Deming in it shortly. But Taiichi Ohno built the Toyota production system. The Toyota production system got translated into all industries, and it got translated into healthcare. And really, since the turn of this century, many, many organizations have used the principles of improvement in healthcare for the sorts of reasons that it was invented way back in the 1950s. And so much so that a recent survey that the King's Fund had joined in with and in America had been done by a consultancy called Catalysis, showed that over 70% of healthcare systems were deeply into using what is often called lean techniques, the way in which the improvement and continuous improvement in manufacturing could be applied to the processes that we run. And in the last 20 years, amongst those 70% of the healthcare systems that have tried to use it or are using it, many have found it to be entirely liberating and completely changed the way in which they've been able to deliver healthcare. What emerges from all of this is that there isn't really an argument anymore about how to do improvement. The tools and techniques of doing improvement are well known, and there's neither an academic argument nor is there a pragmatic, if you like, management-led argument about what it is that we need to do. But unfortunately, the reviews and the evidence also point to the fact that it's much, much harder to do well than you would have expected from these basic principles. So although in the study I was just talking about, 70% of healthcare systems were using some form of lean, only about 12% of them were doing it well. So it seems the subject that we're going to talk about today is hugely popular, well proven, but harder to deliver than at face value it appears to be. And the theme I've got this afternoon is to kind of tease out why I think that is and what it is we can do to make things better. So, and as you can see, I've put a little bullet point there to say just don't think of it as tools. In fact, almost every evaluation of lean application in healthcare draws the conclusion that if you think of it as a toolbox, that's when you go wrong. Even though it is a set of tools, but it's not just a toolbox. The analogy I would use that many of us could relate to is you could almost think of any trade. You know, a plumber, a joiner, an electrician. The tools that they use are pretty familiar to us. Most people know what a saw is, or a drill, or a screwdriver. Knowing what a saw or a drill or a screwdriver is does not make you a joiner. There's something different in the skills of a trade than just knowing what the tools are. So, I thought I'd just pause for a second. And I say I'm delighted to see you all here. I'm also curious to know why you're here, in a sense. And Suzanne's already mentioned there is a problem looming in front of us, which is both the response to COVID and the response to what COVID has done to us in the last 18 months in terms of backlog of work and so on and so forth. So I'll start for 10, I'll say, right, one of the problems we've got to solve at the moment is the consequences of COVID-19. But there are other problems. And I just wondered if anybody wants to kind of shout out a thought of a kind of problem they're trying to tackle at the moment or wrestling with, that they're hoping more insight into improvement might help them with?
Engaging people with evidence.
Sorry? Engaging. Yeah. Say a little bit more about that.
We manage the library service.
Yeah.
You know, and we want to try and embed the practice of building improvement and change.
Yeah.
In best practice, what's worked already elsewhere.
Right.
Embedded in
Yeah.
everyday
Yeah.
work.
And you're reflecting back to me, which I think is perhaps one of the commonest problems of being able to make the transfer from knowing that these tools and skills and so on exist to actually being able to use them. And hopefully I'll tell a few stories that might help, because in my experience, it's the stories that attract people to trying stuff out. Anybody else got any?
I think it's part of the impact of COVID, but I think it's to do with trying to get out of a firefighting mode and into something which is to give you something that gives you that headspace, and to be able to transition from firefighting into the next stage.
Yeah. If Deming was here, I know one of Deming's stories. In fact, I know a lot of Deming's stories. I could bore you. In fact, maybe Suzanne will do another day. We'll say stories from Deming. If Deming was here, he would say, if unfortunately a fire broke out in this building right now, okay, we would have to do something, maybe phone the fire brigade, and somehow or other we managed to put the fire out. Okay? Question, have we improved the building? No. A lot of managers behave as if putting out fires improves things. Doesn't. This building would not be improved by a fire and being able to put the fire out. Firefighting is a completely different kind of area of leadership and management than improvement. They are not the same thing at all. In fact, Deming is very, very dismissive of people who think being busy putting out fires is good work. Now, it's useful work, because obviously if there was a fire in the building, we would not want the fire to carry on. But in terms of making it better for the staff, making it better for our patients, firefighting is not part of our armamentarium. So yeah. Any others?
I think that the very title of this masterclass is why I'm here and what I think we need to solve. I came into healthcare as a nurse in 1981, and I would say that we were more Toyota-like and systematic, following standards and procedures at that point than we are now, and we've just completely lost all of that. We're in chaos, and Deming would say you've got to get stability before you can improve it.
Couldn't agree with you more. Could not agree with you more.
We've not got stability.
Yeah, and it's there's another thing that and I say this with fondness as well as kind of anger, if you understand what I mean. So I'm going to fondly say that we're obsessed with projects, as if building a mountain of projects will improve things as well. It doesn't. You're so right about, again, some of you have heard me talk before would say that there has to be a platform to improve from, and that platform has to be the standard that you can, if you like, with some stability, keep while you try and innovate. If you innovate in thin air, it always falls over. And chaos is a good word, I think, for the situation at the moment, and we've really got to think about how we stabilise. Another way of putting that, I think, is people obsess and have obsessed for the last 15 years with governance, as if governance was going to help us get to quality control and all that sort of thing. And by the way, or challenge me. If I upset anybody at any point, do challenge me. But the thing about kind of governance is it underpins the idea that you've got quality control. And it aids quality control. Most of us have not got systems for quality control. In fact, it's worse than that. To use a manufacturing analogy, and I may annoy some of you by keeping on using them, but to use one, quality control would say, if I want to build a Mini, I build a Mini. I don't halfway through building it think, I wonder if I could make a Rolls Royce out of this. And then sort of try and make a Rolls Royce, fail, and sort of go, well, maybe I'll go back to building the Mini. But on the way going back to building the Mini, I think, well, there's a sort of fashion for SUVs now. Maybe I'll build an SUV instead. And much of what we are doing is not quality control. If the customer's asked for a Mini, build them a Mini. If we're tooled up and can afford to build a Mini to really high standards, and then think about improving it. Don't mess about going, oh, well, we're sort of bored this week. Let's try putting 5 wheels on it instead of 4 and seeing if it goes faster. I mean, you can pursue that analogy too far, But quality control is about that stable platform, exactly as you say. So I hope we can cover that. Now, I'm just going to kind of diverse for a few minutes and just talk about why things feel chaotic, I think, at the moment, and some of the things that are feeding into it. In this chart, if you look at the bottom line, it's a bit complicated, but the bottom line, which is sort of vaguely yellow, as against lime yellow, that is tracking the ageing population. And a proxy for that is the over 85s, okay? The top line, the more kind of lime-coloured one, is total admissions to hospital, both emergency and elective, as a proxy for activity. And as you can see, they're going up pretty much in parallel, although as the ageing population is getting bigger, activity is going up slightly faster than you would have predicted just from the ageing population. And for example, how many of you are involved in primary care in some form or another? Yeah. We know this in primary care, don't we? The kind of the polypharmacy, the extent to which the older population is surviving more, but they're surviving more with multiple problems. And so an 85-year-old today very often is quite different from an 85-year-old 30 years ago in terms of the needs, expectations, the healthcare that they need, and so on. So there's a kind of plausibility thing there. And the middle line, the blue line, is funding. And as you can see, it kind of flattened off. Does anybody remember what happened in 2008-9?
Election.
Well, there wasn't. Yeah, that's when the banks collapsed. And you can see that period from 2003 to about 2010 is the period which was kicked off by Tony Blair. You remember when he said we're going to try and catch up with funding from equal to Europe? Do you remember that period? I mean, basically, they carried on funding in that sort of growth way that you can see is about 30% over that period. And then austerity came and the government changed, you're right. Maybe they changed philosophically, but I do genuinely believe there was less money around. What's interesting about that, this is a study from the BMJ a few years ago. This got quite a lot of publicity at the time, but people have forgotten it, I think, is that for years and years and years, there'd been a gradual improvement in health outcomes, which lies behind the growth of the elderly population, amongst other things, but people were not dying in the same way. And lo and behold, at this roughly the same time, you can see the red line is the actual change in mortality. It stopped improving at roughly the same time. And you can see the authors of this paper then worked out the excess deaths that you can attribute to the change in our population health. By the way, I don't think that's all healthcare by any means. That's all sorts of things that were going on associated with austerity, society. You know, you could argue about housing here, you can argue about jobs, you can argue about all sorts of things, but healthcare is part of it too. There's been at least 20,000 excess deaths for 10 years, based on probably what happened to the banks. This one always intrigues me. Do you remember that time when the politicians came out and said we're going to have 5,000 more GPs? Does anybody know where that figure came from? Well, here's the data that it came from. It came from the fact that between 2012 and 2016, we lost the equivalent of 5,000 GPs. So it was a little political fix to get back to where we had been. And there's a little bit of data here on the GMC as well, and this is well known to those of you it's still in practice, which is the number of 10-session GPs now is really quite small. Now the reason for that is 6 sessions will get you your first 40 hours easily. And a 10-session GP now, we might be working 60 or 70 hours. So it's no big surprise, any of this. Interestingly, the doctors here on this chart are hospital doctors. And as you can see, in the same kind of period, the number of hospital doctors has been going up steadily. But not so nurses and midwives. Anybody here a nurse or a midwife by background? This is really interesting, this. When you look at the change in activity, do you remember that chart I said there's a proxy for activity as all admissions been going up steadily? The number of doctors slightly exceeds, it's 14 or 15%, it slightly exceeds the activity increase, whereas as you can see it's been pretty flat, the number of nurses. So nurses have vastly improved their productivity over this period. The doctors haven't. In fact, the productivity of doctors has gone down slightly in this period. And like you, I can remember the 1980s when, 3 orthopaedic surgeons were doing the work of what 20 do now. Nice. That's an exaggeration, obviously. Any orthopaedic surgeons in the room? Good, I'll carry on making jokes about them. No, I won't, honestly. Clearly, the number of operations they can do has changed. The sorts of operations they can do are vastly improved, and we all need them. But their productivity has gone down. Now, this is interesting. Same place where the change started to happen. This is total people waiting. And right here on the right-hand side, you can see COVID. Now, call me a cynic, but it seems to me that COVID hasn't had the impact you would think it has just listening to the politicians at the moment. I think the reappearance of very long waiters was looking pretty inevitable anyway before COVID. And if you look at this same data a different way, this is looking at waiting times where the dotted lines at the top are the targets that we're familiar with. Basically, since about 2013, there's been quite a steep decline in our ability to hit the targets. I see this as a kind of proxy for the patient experience. In other words, for at least 5 years, the patient experience has been getting steadily worse, whilst the number of people waiting has been getting steadily bigger. Now, I do accept, by the way, that COVID has had a dramatic effect recently, but it's kind of on the top of a very, very long-term change in the way we were doing our work. So if I ask myself the question again, what problem are we trying to solve? We can't solve the money problem, and the productivity problem sounds like something we should be thinking about. And indeed, I would argue if we don't think more about productivity, we aren't thinking about the right thing. And I'll talk about how we might get out of that issue in a second. There's quality. I've already told you my little story about that, but equality in terms of patient experience is certainly going the wrong direction at the moment. There's no doubt about that. I've got this kind of big one for me, which is staffing and morale. I think that's our biggest issue actually at the moment. If you were to press me and say, out of all of these problems, what's the issue? The issue is the morale of staff. And indeed, in some areas, the quantity of staff. I think I didn't mention, you might have noticed, although there was a data change in the middle of it, for those of you who are interested in charts, did you notice the number of managers? Significantly less than it was. Which really means, have we got a crisis of leadership? Is that what the problem is?
Stephen, with quality, I think there's also an issue about equality.
Yeah.
Equality of access to service, equality of various groups in society being able to get the health care that they need.
Yeah, I couldn't agree with you more. And I debated for hours whether there's a version of this slide broken down by socioeconomic groups. And one of the things Suzanne said I've been working with Newcastle hospitals the last 12 months. What's really interesting working for them is their desire, one of their ways out of COVID in a sense, is to redouble their efforts on inequalities. And you may or may not be surprised to hear this, but there's if you look at the proportion of people in each socioeconomic group, the proportion of referrals is heavily weighted towards the higher groups, and the proportion of people waiting a long time is weighted towards people in the lower groups. In other words, we are not only running poor systems, we're running systematically unfair systems. And just to give you one example that we've been looking at in Newcastle recently, and touch wood, put right, is part of the response of the difficulties of COVID and the difficulties of capacity is trying to get people in at short notice off waiting lists, right? And we discovered that the team that were doing that, and this was not deliberate, it was accidental. When people had learning disability or other communications problems and so on, they just didn't bother trying to ring them. And that's a very good example of how there's a kind of systematic inability to respond to what you know to be the problem, which is that group is already overrepresented on your waiting list, and then you give them poorer access to your so-called improvement, which is, if I've got a cancellation, I'll try and fit somebody in it. It's a massive challenge. You're absolutely right. And now you've mentioned it, I wish I'd put that slide in that shows how, if you compare the actual numbers of people, referrals in and conversions onto the waiting list is weighted towards the top end, but people long waiters is weighted towards the bottom end, and it's just unfair.
Is there not also an issue around, I heard another talk once about somebody was rescuing people out of a river, and they were looking at more and more efficient ways of rescuing more people out of the river, until someone said, should we not find who's throwing them in?
Yeah.
It's that question around, where people have increased longevity but decreased quality of life and health. We've got more people who are living longer because of the successes of the health care, but also because of people's lifestyle choices. They're living with complex comorbidities, which then puts increased pressure on the system. So it's not just the health systems are running less efficiently, it's that increased demand. You've got an ageing, healthy population, and actually the healthcare system isn't the solution because we're medicalising lifestyle choices. Yeah,
and it's worse than that. And that is because of the nature of some of the targets, and some of this is media and political, and some of it is us, the customer, our tendency to put most effort onto acute hospitals. So even the so-called healthcare system isn't really a healthcare system. We hugely neglect investment in community services and primary care. We hugely neglect the ability to respond in a social care way. So in fact, we haven't got a system. See, I needn't have done this talk. You already know what the answer is to some of our issues here. But yes, you're absolutely right. One of the reasons we've got to think about systems as against individual components of the system and improving them is, without improving the whole system, you're really not getting bang for your buck, as it were, as the Americans might say. I'll just mention one other problem, which is the obvious one. You've all heard of the second law of thermodynamics and entropy. That everything goes to ruin unless you pour energy in. Everybody heard that before? Yeah, it's a familiar problem that any system you set up gets worse and worse and worse with time unless you put energy into it. So, in fact, one of the reasons we need to improve is to get back to where we were, rather than anything else would be a luxury. But just to stay where we were would be good. I remember a project done a few years ago on Ward 4 in the West Cumberland Hospital. You think about care planning in nursing terms, all good intent. But they'd ended up on Ward 4 with about 13 or 14 different care plans that they were using? Even more than that. And by simplifying and going back to, actually we just need a care plan for frail elderly people, they saved about 20 hours of nursing time a day. You'd think that's remarkable. They needed to save 20 hours of nursing time a day because of the way they were so stretched. So, the problem is complex. And it looks like the big question is, should we be doing? So, what should we be doing? I said it's not just a toolbox. What we should be doing and what the evidence and the kind of the story, if you like, is all over and over and over again is we need to think about 3 sets of things, and here they are. The tools for improvement, the management of change and complexity, and leading these high-performing teams at the same time. And we need to do all 3, and I'm just going to kind of talk about 8 different heroes very quickly to give us that kind of historical perspective. And let's start with Deming. My favourite point about Deming to remember is it's not the people who are messing up your processes, it's the process that's messing up the people. Hands up who's ever come across a manager who thinks it's the people who are messing up the process. It's not. It's not. Your problems are with the processes, usually not with the people. This is expressed in all sorts of different ways. A common way of expressing it is most people come to work to do a good job. Ever heard that cliche before? It's true. That's what the surveys show. We would like to do a good job. Are we given the conditions to be able to do a good job? Not always, by any means. And as we've said, Deming, improving things is not the same as firefighting. Any of you want to find out more about this, go back and read Deming. Or even, you know how you can Google 50 top quotes from Deming? Just reading those 50 top quotes will reinvigorate you. I can absolutely guarantee it. What about Taiichi Ohno? I mentioned before that Toyota originally was a textile industry. And if you just think about what you know about Japan, maybe not much, but we've all heard of the big families. Toyota, Mitsubishi, it's moved on its own. That's clever of it. Mitsubishi, Hitachi, they're a cross between a Scottish clan and a medieval fiefdom. They're families, in other words. And what the reason I think Taiichi Ohno was able to be successful was an improvement is he started from the basis of these workers are members of my family. And I am trying to improve the work because their work is awful. So the improvement science in Toyota goes back years and years and years to when people had back-breaking, labouring work and they tried to improve it. And you need to know no more. I'm sure everybody in the room has seen this slide before. You really need to know no more than Taiichi Ohno is crazy with the idea that we make our staff do 3 things. The useful work, the little lime green value-added bit, the bureaucracy of the job, the non-value-added bit, and waste. And getting rid of waste is the thing you need to do. Reducing bureaucracy, reducing those care plans, is the next best thing to do to give us space. And if it's not waste, this is Gary Kaplan, the third person I mentioned, who's famous for Virginia Mason bringing in healthcare 15 years ago, bringing Toyota into healthcare. And that's him staring at a semi-automatic loom that stops itself if the thread breaks. It's one of the first examples of mistake proofing. And many, many people, I think, that you come across will see improvement in terms of big projects. If you just remember waste removal and mistake proofing, you'll get it right. So the only tools for improvement you really need are waste removal and mistake proofing. Everything else is superfluous. Challenge that one if you like, but that's the place to start. Now, managing change and complexity is my kind of second point, and everybody's familiar, I'm sure, with John Kotter. John Kotter's 8 steps for change. John Kotter's probably one of the people who really got the idea that you've got to know where you're going. So your vision, your statement of intent, your objectives, as we often call them, are really, really important. But the steps start, that's step 3. And most of our leaders, and most of the time we do it as well, we forget that. We jump into step 3 and set some objectives before we've answered the question why, and why bother, and before we've built the team to do it. And again, I cannot emphasize this enough. This is a mistake that goes over and over and over and over and over. People start with a vision and then try building a team and then try having a communication strategy to explain why the vision is the right thing. That's not what Kotter says. What Kotter says is, have a real deep conversation about why you've got a problem, build a team, and then that team sets the objectives. So, waste, mistake proofing, follow Kotter's steps. I mean, how hard can it be? This is so well studied. It's been known for 30 years, and over and over and over again, people get this wrong. They jump in with objectives and then try and build a team to deliver the objectives. Wrong way round, Kotter would say. So the management of change, I think he's rather cynical about, we're not short of vision and clever ideas. And to translate that into our day-to-day work as kind of middle managers delivering stuff and so on, how many action plans have we got? We're not short of those things. What we're short of is the discipline of the sequence. And team building, remember, was right in there. And the second one, those of you who've heard me talk about this before will know I'm a fan of this. Everything doesn't need to be fixed all the time. Right? Ron Heifetz says that the biggest mistake we make as leaders is seeing everything as a problem that needs to be fixed. Instead of going, boy, this is a complex problem, I have no idea how to fix this. And then going to your team and saying, anybody got any ideas? Again, how hard can that be? Well, turns out to be really hard. But complexity, in summary, requires these sorts of things. Humility, the ability to delegate to your team. Experiments, coaching. When we were around in the 1980s, and I was a junior doctor and you were nursing on the wards, there was a chain of command that was very clear, wasn't there? But it was equally true that the staff nurse on duty at night had autonomy and could do stuff and fix things herself, experiment herself. I think sometimes, again, going back to the idea of governance and so on, leadership has sucked in too many decisions to itself. When complex problems require that delegation and that experimentation, and ultimately co-production with our patients. Because what Toyota have shown, and people like Gary Kaplan and Virginia Mason have repeated, what Ron Heifetz says about complexity, but it fits with John Kotter's idea of change management and so on, is it's not us who decides what's really valuable, it's our patients. And we need to listen to our patients more and co-produce with them if we're going to get through any kind of complex problem. And I hope I've given you enough kind of ammunition to reflect upon, to think about, it is a really complex problem that we're facing at the moment. It's not just fixable by setting up a PMO and hiring a few improvement leads. That won't work. Just won't work. So, we've got tools. Most important, waste improvement, mistake proofing. We've got a way of managing and thinking about the problem, which is actually about building teams, delegating to them, and managing complexity. It's a thinking method. And we've got loads of evidence, my third kind of part of the thesis, if you like, about how to build high-performing teams. Edgar Schein, another, Google 50 quotes from Edgar Schein. Nobody reads anymore, do they? Apart from me, perhaps. But, the reading's really important. Read Edgar Schein after you've read Heifetz, after you've read Deming. Leaders underestimate the impact that they're having. And that one of the things Edgar Schein has pointed out is that the staff are watching leaders all of the time, saying, if you ask somebody in your team to do something, their immediate human reaction is, I wonder if they really mean it. And then they'll wait to see whether you mean it or not, long before they'll actually be empowered. I can't empower you by just saying, be empowered. I can only empower you by genuinely, over time, reassuring you that I'm interested in your ideas, and so on and so forth. Michael West did some research, you can see here. Mortality goes down if you've got a high-performing team. Why isn't that talked about more? Quality goes up if you've got high-performing teams. Now, that's not a secret that I've just suddenly revealed. We've all known that from our own personal experience, have we? And anybody here from Morecambe Bay? Yeah. What did?
Raise my hand to that.
Yeah. What did Jackie set out to do when she arrived?
I wasn't there.
You weren't there? Improve morale was the answer. Because, as Michael West has shown in a number of bits of research, happy staff saves lives. Now, did we need to do some research to find that out? But what Michael West then went on to do is this rather famous research of all the features of high-performing teams. Again, it's not rocket science. It includes things like good HR. Anybody here from HR? Do you know, if I could have my time again, I would have HR as top of my list of things to get right. Because we want to recruit people well, we want to induct them well, and we want to treat them well. We don't want to be messing about with their expenses and stuff like that. As I said before, there are really 6 features here that all correlate with a high-performing team. And I just want to emphasize one, which is the underlying values. Suzanne's our resident expert in OD here, but we don't have enough conversations, I don't think, about values. If you want to build a high-performing team, the leadership has to be this collective, shared value thing. It can't be just telling what to do. So that sense of values-based, well-organised, strong objectives and stuff, but following in a particular pattern. And notice that continuous learning and improvement is just one feature of that high-performing team. Again, I think a mistake we do with improvement sometimes is push it into low-performing teams. It'd be better to sort out everybody's grievances about parking expenses and mileage first than give them improvement tools, is what my conclusion from what Michael West says. In other words, we need to be well organised, well managed, sorted out. We need to be clear about people's job roles. The work I've just been doing in Newcastle, we've recruited over 1,000 people who haven't previously worked for the NHS. We just said, let's be really clear what the job roles are and the job descriptions. Let's induct people into those job descriptions and so on. It's dead simple stuff, but it goes along with those tools. There's something else happened in 2007-8, other than the banks collapsed. Anybody remember? Mid-staffs, it was mid-staffs. And that kind of exposure of the wrong kind of culture, the non-learning culture, the blaming culture, the board who were only interested in hitting targets and not really interested in what was actually going on their wards. That was the mid-staffs experience. And again, some of you will recall, and it's worth going back to, Don Berwick's review of what is it that causes that kind of blame-laden, aggressive management culture? Or to put it another way, what's in the evidence that talks to having happy staff who are engaged, who understand values and so on and so forth? And again, it turns out to be relatively simple things. And part of my hypothesis, which I want you to reflect upon, is we kind of know this stuff, but it's not implemented as if, because it's common sense, we would do that anyway. So let's have a PMO and do some improvement, rather than see this as part of your integrated goal. So you'll notice that respond to complexity, improvement science are in there. The same evidence base that people like Michael West were using, that build on academics like John Cotter, keeps recurring whichever angle you look at this problem from. So, I've drawn it here for simplicity, as if this was a kind of linear, go away and do all of these things and it'll all work. Of course, it's not really like that. And my first kind of argument for a system is this one. This is the system that we need. And it's a system of thinking, acknowledging complexity, actually watching out for things like Cotter's change management rules, tidying up HR processes in your team and stuff. It's a way of thinking that goes alongside the improvement tools. As I said, if you know nothing about improvement, just think about waste and mistake proofing. For the very reason you were saying right at the beginning is we need to stabilize our current way of working. If I could have my time again, what did I say before? If I could have my time again, I said I would focus on HR, wouldn't I? There's something else I would do as well. If I could have my time again, I would refuse to do any service redesign. We're obsessed with service redesign. Pathway redesign, this, that and the other. It's called all sorts of things in a situation which is chaotic and unstable. Apart from anything else, how do you know the new system is an improvement if the old one was so chaotic you couldn't even measure it properly? We need to de-emphasize redesign and emphasize waste removal, mistake proofing. And mistake proofing is much bigger than the old, you can't plug a nitrous oxide feed into an oxygen line and vice versa with an anaesthetic machine. Everybody familiar with that idea? That's a classic example of mistake proofing. You couldn't accidentally give everybody who is under an anaesthetic pure nitrous oxide when you wanted to give them oxygen. Obviously that would be a bad thing, the patient would die. So you can't accidentally do that. That's mistake proofing at a very practical level. But mistake proofing is, our processes need to be mistake proofed as well, because when you look at our demands, very often they're things from patients because they didn't get satisfaction the first time. Some people call it defect demand sometimes, but our system is full of this requirement to put right something that upstream was already being done wrong. Get back to your analogy of where our energy goes into rescuing situations rather than fixing the broken bridge upstream which is causing people to fall in the river. And we're tired because we're rescuing people all the time. We have to force ourselves to fix stuff higher up the line. And And the foundation is actually this idea that we are team builders. And this is a system. We cannot be improvement scientists without being complexity and change management gurus. We can't be any of those things without our ability to build and sustain teams. Because the foundation of the system is the team. It's, in other words, and this is not my thesis, this is my kind of explanation to you of what the evidence says. What the evidence says is the tools are very interesting, and we've all heard of PDSA cycles and flow, and Suzanne said one of the things we might mention is one of the things I've been doing in Newcastle. We built a new PCR lab, one of these lighthouse labs since last September. Started out with an empty shed in September and built something that's capable of doing 80,000 tests a day with, as I said, staff who hadn't worked in a lab before. From day one to when it opened was just less than 6 months. And it was all done using the tools of Taichi Ono. We worked out the takt time, we sorted out what the flow needed to be, we simulated it. We had it all, we actually had a video of it working before it was even built in simulation. And then when it built, lo and behold, it kind of worked. So the tools are more complicated than I've said, although I sincerely believe we must do more waste extraction and mistake proofing. And then we need to get back to thinking of it as this system. It's not linear. It's not somebody over there does the team building and somebody over here does improvement. It's we're all good managers. And we're good managers because we can integrate this in our thinking. The Royal College of Physicians have also thought about systems thinking in this sort of a way, and mentally thinking of it like a funnel, not a tunnel, a funnel. And that when you first identify a problem, there's some kind of trigger to the problem, and you're in that, what is it? Why are we what is the problem we're trying to solve? Question. It's all kind of big and vague and mushy. And it's through those experiments and iterations that you eventually get to where you want to be. It's not just a project where you have a committee and design a new pathway or whatever. It's just not like that. And more and more people are coming around to this idea that you start with wide parameters and lots of complexity. And it's only through iterating it through lots of experiments that you get to a point where the whole thing's working better. And it's only by thinking of it, whatever the trigger is, the waiting list, a serious incident, whatever it might be, think big to start with. How many of you work for the North Cumbria Integrated Care? How many of you immediately think of, how can I help them in primary care when you've got a problem in the hospital? It's not how we're taught to think, is it? The people rushing around at 2 o'clock in the morning trying to find beds rarely say to themselves, I wonder how we could help Chuck more. You're just looking for another bed. They are not systems thinkers. They're not even following their own guidance of their own colleges half the time, in the sense that you've got to think big before you start iterating towards a solution. So you have to be a system in your own head, and you have to think of the healthcare system as this big, broad thing that includes everybody before you experiment down to what your solution is. Yeah?
It's not quite entitled to ask this. It might be something to reflect on and talk about later, but I'm with you on the fact that we're redesigning systems and pathways, But there's an element of where they need to be designed effectively as well, because we've broken them up. And so what you're saying, like bed managers, you push every patient into gynecology, and then the gynecology patients don't get to the gynecology wards, etc., and on it goes. It's like we need to get back to getting a system that works and flows the patients properly to where they need to be.
Yeah. How do we do that?
And I suppose I've been labelling that as redesign, but actually it's just basic design being right.
Yeah.
Start thinking about new ways of doing things differently.
I think for me, one of the ways of thinking about this is that what I call the mistake proofing, the defects in the system as it is at the moment that need taking out of it, as it were, and the waste that's in the system. And this isn't to talk about, the technical nature of the tools. I know that many of you really understand this. But it's really saying, before I think about what really needs to be fixed, which is what everybody is, step back from it and go, I just don't understand this problem enough yet. Start in a big, wide funnel and say, probably the first people I need to talk to is the GPs, or probably the first people, instead of constantly thinking, right, this is the bit I'm in control of, which bit can I fiddle with next? It's true for the GPs, of course, as well. They need to think broadly in the same way, but you're absolutely right. We need to stabilise the current system, which I would argue is change your thinking, concentrate on making the staff happy, and then take some waste out, would be a lot better than a big project to redesign the pathway for, day case surgery or whatever it might be. Whatever it might be. And I think these two models, in a way, this is the simplest of the lot, is saying it's not linear, this. I'm not giving you the sort of snippets of evidence and saying kind of learn it all and just line it up. Think of it as churning around, but the foundation is the team building and the happy staff. And when we're thinking about healthcare, every single project we go into, we should think of it like an enormous funnel that only one day will we get to measurably better. And you don't do that by one leap, one design leap. And we've tried to do that often. And as I said, it's a bit like, that old cliche of how the reason IT doesn't work properly is it's sort of layers of programming sitting on top of each other and everybody's forgotten what's underneath. I think many of our processes are the same. So, the problem is complex, it's big, and actually, the big question turns out not to be, what should we do? But why are we not doing it? Why? What's holding us back? And that's the kind of reflection. And, before we break, the good news is we kind of are doing it. And if I take a kind of historical perspective on this for a second, there were some very, very enlightened healthcare trusts 25 years ago who, on the back of the safety agenda, began to look at the tools from manufacturing and thinking about mistake proofing, taking waste out of processes and so on. And they rapidly became famous because they were the only ones doing it. People like Leicester and so on. Then, in the northeast, where I was working, there was again a kind of purple period when we very much focused on the vision and objectives for a while. We had a vision, the 7 no's. Has anybody ever come across that before? It's kind of 20 years out of date now. But that was built on the Institute of Medicine stuff on, actually we'll have no waiting. Never mind the target for how many people wait 18. Let's have no waiting. What would it require for us to have no waiting? We didn't talk about safety. We talked about no unnecessary harm at all. What would it take to do that? And we went through that kind of period of really rapid improvement on the back of strong vision, which led to the Northeast Transformation System in terms of a method to do that. If we had a strong vision, what was our method to do it? Learning from Virginia Mason. There's been a second wave of Virginia Mason trusts, again. Leeds are probably one of the most famous at the moment. And I was at a conference just before COVID where the chief exec of the Leeds Trust was stood up talking about it as if he'd just discovered something new. Naturally, I put him right over coffee. But as I said, I think we need to stand on the shoulder of those giants like Deming and say, the argument's over about what to do. The question becomes how we do it. NHS Vital Signs is another programme of a dozen or so trusts who've been trying this. And I've been involved in coaching some of the chief execs on that, and they're doing well. There are plenty of other providers. So another lesson is the evidence tells us we can be agnostic about exactly what package of tools we use. In other words, all of our screwdrivers don't have to be Stanley. You know, they could be made by Harris or somebody else. You know, they could be basic ones bought at B&Q. They're still screwdrivers. So we can be agnostic about the exact package of tools. What we can't be agnostic about is that system thinking. CQC, as you know, really since Berwick did that review post-mid-staffs have said they look for improvement as part of the leadership equation and how trusts are working. And of course, CLIC is a good example of a system trying to go on that journey and think, how will we get there together eventually? Which leads me to Karen. So we're going to have a break. Kim tells me there's juice and biscuits, possibly. So we'll have a comfort break and we'll come back in about 15 minutes. Karen will give us a worked example of what we have been doing. And then we'll kind of wrap up the reflection, say that, and take questions and think a little bit more about, so practically, what are we going to do then? It's all very well, Stephen, you telling us all of that, but what are we going to do? Okay? Anybody wants to come and pin me against the wall with a really good question, now's a good time as well. Thanks very much.